A pleasure for me to share this session with Dr. Tarnow, who I greatly admire. Thank you so much for joining me to discuss our
My pleasure.
paper
My
uh,
pleasure.
and this systematic review and meta-analysis that we performed with my group to actually assess the incidence, the prevalence, and the main risk indicators and factors of peri-implant diseases, which are mainly related to patient-related factors, behavioral factors, and also systemic factors. So we have a lot of nice and interesting evidence that came out from this systematic review and meta-analysis, Dr.
Maria,
Tarnow.
were there any, first, thanks again for having me here on the podcast. Were there any findings that you were kind of surprised at in your research that you came across?
So I think something that really called my attention, even if my main research line is the treatment of peri-implantitis, is that this systematic review showed that after 10 years, almost 50% of the patients will be diagnosed either with peri-implant mucositis and peri-implantitis, which I do believe is extremely high. In your experience, Dr. Tarnow, do you see this in your daily practice after treating so many patients?
I don't see 50%, thank goodness. That number's high, but we should talk about that. I think the biggest problem that I saw with all of these papers, not yours was a meta-analysis and review, but what I find the reason for the diversity being so great, the numbers as you plotted out could be anywhere from a few percentage to 60, 70, 80%. And I think the viewer should see the reason for the difference. And that is, how did they measure peri-implantitis? And it was different for each of the studies. You did, well, how many studies did you look at? 100 and some odd papers you included? If I'm not
Yes.
mistaken, over 100 papers. And they all didn't have the same criteria to say that, oh, this is peri-implantitis. They had different amounts of bone loss. And some people could be 2 milliliters, some 3, some 4. So it's going to be completely different. And I think that was a big factor when you have to do a meta-analysis, but you can't, you're trying to get a feeling for it. And you did beautifully. I give you great credit, but that's the reason why you see such diversity. But I think we both agree, if you don't dispute it, Maria, from what you see, it's at least 10% of cases will have peri-implantitis.
Yeah,
That's the
I totally,
minimum. That's the minimum that we see, 10 to 15% over 10 years.
yeah. And
Would you
then
agree with that
almost
statement?
Yeah, I agree with that statement. And I actually agree that the lack of having like a standardized criteria does make a problem to us when researching. For
Right,
example, 102 studies were included, and only 19 of those, so 20%, around 20%, actually follow the standardized World Workshop definition of this consensus of 2017. So
right.
actually, this is exactly the main problem. I would say that yes, peri-implantitis should be expected between 15 and 22%, but mucositis is for sure more common, and
Sure.
actually this could be around 50%. And if
Right.
not diagnosed and treated on time, will be converted into peri-implantitis for sure.
Yeah, I couldn't agree more. Mucositis is like gingivitis, of course, supracrustal inflammation, and we see that on our teeth, we see it on patients, and this is to be expected. Just a number of years in the mouth will automatically determine that it's going to have a certain exposure to gingivitis with all different patients. So I think that mucositis is a given. I mean, you're going to have it, it comes and goes. Your cleanings will take care of it in most cases. And I think, if anything, it shows how we have to get to the point where we do great recalls as clinicians. We have to make sure that we got these patients on 3-month recalls, not once a year. Oh, come in. The problem, I think, with implants in the past is that we know they don't decay. So patients, say, oh, it doesn't decay, oh, it must be forever. They forget, of course, about maintenance periodontally. And that has to be reinstated by the dentist. I think that's an important clinical point I want to make.
Yeah, and I do believe certainly this is also one of the problems we have in the present research and evidence that we could determine the risk indicators, but not the risk factors, because we do not have actually enough longitudinal evidence to compare this. So actually, from the few interventional studies that were included in this systematic review, we could see that, for example, patients with history of periodontitis or erratic maintenance compliers, or patients that were, for example, fully edentulous, these patients actually showed a higher incidence of peri-implantitis over 10 and 20 years of function. But this is exactly what you mentioned. If the patients do not comply to maintenance, or for example, they had a history of periodontitis, and then this periodontitis is not controlled, and they have dental implants, and this periodontitis becomes active over this period where they are not having any control, of course, they are more likely and prone to develop these diseases. So I feel that a way to actually also understand better the new evidence and what we should do in new studies is to do and perform interventional studies that can
Right.
control and compare these two variables, like erratic maintenance compliers versus the ones that comply, and then actually see how this can be a very important risk factor. But still, this paper could not demonstrate risk factor, but only risk indicators.
Right. I think that certainly there have been certain studies that show that people on 3-month recalls do much better, less bone loss than the patients who periodically go and see this. Dirks, for example, had that beautiful paper with so many thousands of patients, and I think he showed that tendency. In fact, we didn't talk about prosthetics, but contours of crowns, way things are fitted, all play a factor, and has been shown. Dirk showed that there's a 4 times odd ratio increase of breakdown periodontally if the work is not done properly by, let's say, an average general dentist who may not pay as much attention to detail as a prosthodontist. And in the study, he showed over 7 or 8 years that patients treated by prosthodontists had a much better turnout periodontally than others. I think that does show restorative dentistry is also a factor on this, in follow-up. I think that's important.
Yes, 100%. And actually, part of these consensus papers also show, like, as you mentioned, the emergence angle when it's greater than 30 degrees is
Right.
actually a risk indicator for the development of peri-implant diseases. And also, this call our attention because this paper is mainly focused on patient-related factors. But we understand that peri-implant diseases are actually or are derived from a complex interaction of different factors that are systemic, local, prosthetic. And yeah, I do agree that the more we understand about prosthetics in the future, the more we can prevent peri-implant diseases, because the aim of this systematic review and all the systematic reviews and meta-analysis of this consensus are actually to be able to develop new strategies to prevent and mitigate the onset and progression of peri-implant diseases, which has become, unfortunately, a real problem for clinicians all around the world.
That's great.
Um,
One of the things that came up in the consensus is the definition in 2018, 17, whatever,
yes.
is what the definition is of peri-implantitis again. What if the patient, you've never seen the patient before, versus a patient that's been in your practice for years and you have previous x-rays to go by? If you have previous x-rays to go by, then it shows the changes in the bone level, increased pocket depth, probing depth, all become pretty clear. What if a patient just walks into your door? First time you're seeing them today. How do you determine if the patient is truly has peri-implantitis? And I think the consensus that we came up with, I was part of that consensus. And the consensus we came up with was that the pocket depth should be 6 millimeters. It should be bleeding on probing, of course, signs of inflammation, not just pocket depth. And you
Mhm.
can't say increasing amount of bone loss because you don't have, if you can't get previous x-rays from another dentist or yourself. But the amount of bone loss was listed as 3 millimeters from the abutment connection, greater than 3 millimeters. We called that was a pretty agreeable standard. So 3 millimeters of bone loss on X-rays, you never saw it before the patient, never saw the patient before.
No
Uh,
baseline. Mhm.
no baseline. And I think that's an important point maybe to bring out to the readers, to the listeners.
Yeah, 100%. In fact, when we were performing this systematic review, it was like this was a surprise how we have so many definitions, as you mentioned before. And this makes it more difficult. Actually, one of the exclusion criteria of this systematic review was when the studies will not consider, for example, radiographic evidence, radiographic parameters to diagnose peri-implant diseases, which is crazy to understand. But yeah, there are many studies that actually still do not consider any radiographic criteria to diagnose peri-implant disease, which for us talking about this makes no
It's
sense. We need
ridiculous.
to understand the bone. But also, as you told, the threshold, 2 millimeters, 3 millimeters, 4 millimeters, if we do not standardize this criteria, we're in big trouble to give worldwide recommendations because still we are in this, how can I say, doubt of how the studies were performed. And we, of course, perform the meta-analysis based on the data that these studies give us. So even though there's a lot of amazing studies, we still lack this standardization.
You
So
know,
Mhm.
sorry. On that same note, there's an excellent article by Codsland in 2010, and
Yes,
he looked at the same group of X-rays, and he used two different criteria of amount of bone loss to see whether or not there was peri-implantitis. Same X-rays in the group, and he showed that if he used only zero point 0.4 millimeters of bone loss, he had 47% peri-implantitis. But in the same group of X-rays, if you use 3 millimeters of bone loss from the abutment connection, it was only 11%. So we went from 47% to
to 11.
11% by changing the amount at the same X-rays being looked at by the same people. Unbelievable to show how what you use as your criteria, as we discussed, is critical to that.
Exactly. And also, Dr. Tarnow, I would like to discuss with you how we also determine bone loss. As you said, if we don't have the baseline, how can we explain that is a progressive bone loss? We cannot because we have not seen the patient previously, right?
Right.
But of course, bone loss can be we can see it in a radiograph, but maybe bone loss started even before. Maybe if we would have a histological section and we analyze it with a microscope, we can even see it when it starts to have point 0.5, point 0.2. So I think sometimes numbers, exact numbers, cannot give us the real diagnosis
Right.
because for sure, in your clinical practice, you've seen that you treat a mucositis case and it does not get resolved only with non-surgical therapy. And you see the recurrence and the recurrence, and maybe this was peri-implantitis, but just the definition maybe was not accurate enough to be customized to diagnose this patient in particular. So I think this is also a problem because maybe the 3 millimeters and 2 millimeters we have in the current worldwide criteria developed in 2017, 2018, maybe still has certain limitations because we do not evaluate, for example, the buccal and the palatal bone levels
Mhm.
with this
Right. Not with
definition.
X-rays, of course. We do that with probing depth, as you know. But I think
Yes.
that, listen to these numbers. There's on average 5 million implants in the United States alone, not even counting the rest of the world. 5 million implants are estimated to be placed every year in America. So if 10% at the lowest number, we think it's more like you said, 15% of true peri-implantitis, whatever criteria you want to use, over 10 years.
Mhm.
That's a lot, that's a 500,000 implants that will need attention. That's amazing. So periodontists, don't give up your practice if you don't, you got to start dealing with implants. We'll hopefully get better. And then we didn't even discuss the different implant surfaces being a potential risk factor in terms of rate of breakdown and also, but the rougher once it's exposed, clearly different than the machine top. And that's why I came up with the hybrid implant years ago. 30 years ago, I came up with the hybrid concept, machine top and a textured bottom for bone support. But the machine top was there to help resist peri-implantitis. And I think that this is now that all the companies are shifting to a machine-like top for that purpose to help resist peri-implantitis if it does get exposed to plaque, so it's not as much of a factor. And there's also the
Yeah.
one-stage and two-stage implants clinically. Dirk's article showed that the one-stage tissue level implant had, because there's no microgap at the crest, had less bone loss than all the bone level. So I know that's got to make some companies happy because they have the tissue level implant, but but we can't use it everywhere, aesthetically and otherwise. But there's no question that the type of implant you choose and the surface texture on that implant and where that surface texture is can become a critical factor over the years. not just initial success, but long-term periodontal success.
Yes, I completely agree. And Dr. Tarnow, also to explore a little bit what the pooled estimates identified towards the main risk indicators of this paper. For example, we found that obesity and the metabolic syndrome were associated with the prevalence of mucositis. In your practice, have you seen this? I mean, it makes sense. We know that certain
Yeah.
systemic problems can affect.
It's a great
Um,
question, Maria. I have only seen it when it really gets gingivitis and mucositis. I see it so many different types of patients, fat, old, thin, young, doesn't matter. Good
yes,
hygiene is still the key. But the resistance to peri-implantitis definitely is a factor for medical status. I've seen it over the years, having patients for 20, 30, 40 years with implants. I've seen it when something metabolically goes wrong. So it's the out of control diabetic. And we know that they
exactly.
can't have perfect control every hour, every day. But the out of control diabetics will clearly have more breakdown on teeth and implants. Well established. We all know that.
Yes.
That's that's one. And the wound healing is going to be less. You know, as we all know, the protein synthesis is less. They're not going to heal as well. When you place the implant, they need longer to heal. The bone deposition isn't as fast. Soft tissue might become more inflamed more easily. Protein synthesis is down. So you have all these metabolic things. And the other people, which doesn't come up easily because there's not enough numbers, is people on chemotherapy. I have seen patients on chemotherapy that I've seen for years, and suddenly all the whole systems, of course, are knocked down by the chemo. It depends on which one they do. And the body just can't tolerate it. There's no immune resistance anymore, and the bone just goes down real quick. So that's something which I know you probably didn't look at specifically, but it's not often, those group of patients, not usually part of the studies,
Exactly.
but they're out there.
Yeah, unfortunately, we couldn't not have this group and this
Sure.
fact type of patients going through chemotherapy. But something that is interesting is, for example, diabetes mellitus 100%. This was
Right.
identified as a risk indicator for peri-implantitis. But what we're missing still, and why I would like to bring this out for future research and for the many students that see us, is that we need to actually identify if they are controlled or uncontrolled diabetic patients,
Right.
because in the study
Exactly.
they do not mention this. So my pooled estimates are in general diabetic patients, because unfortunately this is not specified in many of the studies. So
Right.
it's something more general. And understanding that diabetes has a prevalence of 8% worldwide is something we really should pay attention, because all of us will be placing implants in diabetic patients. And we need to
Right.
understand this, that they might have more problems in their per-implant outcomes over the short and the long term, because they are immunologically compromised.
Maria, you also in your paper showed smoking as a factor. You want to talk about that? I thought that was a very important point also, that your meta-analysis showed smoking as a risk factor.
Yeah, 100%. So smokers, we know that affect healing processes, the immunological system of the patient, and we understand that smokers might have many problems in their system. And specifically, when we talk about periodontitis, for example, we already know is a confirmed risk factor. For peri-implantitis, it's a confirmed risk indicator, but we understand that these patients will have a higher odds ratio. And also, it's interesting to see, for example, in a study of Rinke and collaborators, he found a 40 odds ratio for patients that were a smoker, which is extremely high, 40
Yeah, very
chances.
high. Mm.
But what was interesting about this study is that many of these patients that were included in this study had also history of periodontal disease. So also the combination of certain factors might make or might provoke these patients to have a highly more likelihood to suffer from this type of diseases. So I think this is also interesting to understand that the moment you have two factors that are confirmed, like such as periodontitis and smoking habits, for sure this patient will be more prone to develop any disease. Many studies actually in the past also showed that maybe smoking had no effect on peri-implantitis, but I think was mainly because they could not tell how or quantify how these patients, how many, for example, cigarettes they consumed in a day, which is also
Right.
a very important factor. So also in this systematic review, we
I think
couldn't
that's extremely
verify.
important. I think that's
Exactly.
extremely important. I'm glad you bring it up because the patients that I know that smoke like a pack a day and are open about it, they're the ones that break down without question more than the people who are under 10 cigarettes a day. I don't have
Exactly.
that, but that's a clinical, opinion based on doing all these years of smokers, all, who definitely don't show as much problems, but they're under 10 cigarettes a day versus over 20 a day, a pack a day.
20 or 30 or more. And also, Dr. Taran, nowadays we have also vapors who, like,
Yeah,
we don't have this
we
data
don't
in,
even know, right? We don't even know it's
but it's
another whole world,
common.
right?
So it would be interesting also to include this because now
Yeah,
vaping is very common and among the young population, they think it's cool or and we know it's not good for the health, but
right,
for sure it can also be a problem for our implants. So this should be also a very important factor to consider in future studies.
right.
Dr.
Well,
Tarnow, we couldn't find a significant association because we still do not have so much evidence between the consumption of antidepressants and the prevalence of peri-implant diseases. What is your experience, your clinical experience related to this particular
I'm
factor?
glad you brought it up because there's so many things now, maybe definitely affecting the success rate of initial osseointegration. We see that with the protein pump inhibitors. We're seeing it with SSRIs, serotonin uptake inhibitors. There's no question that the results are showing that it's between 3 to 5% difference
Hmm.
in success rate. Now, these good studies, there are some good studies now that are showing that. And whether or not that translates, that's just initial success rate of your implant. It's survival just upon placement.
Yes.
And whether or not, as you pointed out, that has a problem with periodontal disease or peri-implantitis. We don't really have a good understanding yet. I think that's a great study, or on different, and each one has to be looked at differently. There's no question that some patients clearly have problems with their medicines in terms of what's affecting their wound healing. You do an implant, bone is normal, bone is there, no grafting, and yet they react so differently, almost like an uncontrolled diabetic. They just don't take to the bone easily. But those are few and far between, thank goodness. But it's 3 to 5% of the population that you might see an effect like that. And I think that's important. When you're dealing with
Yeah.
3 to 5% of 5 million people, ooh, look out.
Yeah. Because every
That's per
patient,
year. That's per year, every year. So we're gonna have a lot of people
a lot.
to do.
Especially after so many years of practice, these
Exactly.
really become real numbers. What about
Right.
vitamin D? What is your position
The
towards
what?
vitamin D?
Vitamin E
Yes,
or D? Which one do you say?
D, vitamin D.
D. Well, I think a deficiency of any vitamin is a factor. Vitamin D with calcium, but you'd have to show a true deficiency. Now, I know recently, about 5 years ago, they upped the dose that they think is what's deficient or not deficient. They said that everybody who lives in New York City, for example, is deficient with vitamin D because there's no sun. Because you
Uh,
got tall buildings. But I
Different than
think,
South
yeah,
America.
right. I think that has to be more on the extreme. And I don't see any true validation unless you have an extreme deficiency of any of the vitamins. I don't see that as a major factor. But, I don't think I've seen enough proof on that one at all.
Yeah, I
But,
agree, Dr. Tarno. We didn't find this as well for this systematic
right,
review. I think it would be more be towards the initial phase of osseointegration rather
right,
than a prevalence of pre-implant diseases, which is more like a complex interaction and with no doubt so many systemic aspects, patient-related factors, but also local and prosthetic factors that all come together. And if a patient has this addition of factors, for sure,
right.
will be more prone to develop these diseases.
Well, I think we got to come down if we summate this. First, congratulations again on your great paper. I know how long it took for you to probably put this together. Just an unbelievable amount of work. So congratulations on the paper. I think we can walk away with saying proper implant placement, proper contour of crowns, proper recall and hygiene, all of which are critical, and proper prosthetic design and fit, I think is all part of this. And of course, maintenance of good medical controls and with the hygiene. That combination will keep you and prevent you from getting the peri-implantitis. So Maria, thank you
Yeah.
so much for having me today. I really appreciate it. Congratulations on a magnificent paper. Beautifully done.
Thank you, Dr. Tarnow. Thank you so much for your input and feedback on this paper. Your
No
clinical
problem.
experience is a real treasure for all the young colleagues and for everyone. And I would like just to say that, yeah, this paper brings important evidence. And the most important thing should be to understand that prevention strategies should focus on managing the modifiable systemic risk factors, including smoking, diabetes, obesity, and other existing periodontal or diseases. So
Agreed.
I think the main thing should be to educate patients about controlling these systemic conditions and also to avoid or stop these harmful habits to reduce the progression of peri-implant diseases. This will be the main, would say, advice that I can give to our colleagues. And I really appreciate your time and your feedback in
Thank
this.
you. I'll see you next week at the Harvard conference.
Thank you, dear Dr. Tarnow. See
See
you
you next
soon.
week.